Okay, let's dive into this explainer. We're hitting rapid-fire, absolute high-yield exam questions on surgical epidemiology and clinical practice today. A patient exposed to certain risk factors will lead to the development of a particular disease in the future, compared to those who are not exposed to such risk factors. Is this A, case control study, B, cohort study, C, adoption study, D, twin concordance study, or E, none of the above?
Correct answer, B, cohort study. This is a study design that tracks individuals based on their exposure status over time to determine the subsequent development or incidence of a disease.
Let's lock in these exam pearls. Remember, a cohort study moves forward from exposure to directly measure relative risk. A case control study looks backward from disease status to measure the odds ratio. And a cross-sectional study evaluates exposure and disease simultaneously to assess prevalence. New cases of a disease or condition occurring in a specified time and population is known as A, incidence, B, prevalence, C, point prevalence, D, lifetime prevalence, or E, none of the above. Correct answer, A, incidence. Incidence quantifies the velocity of new disease development, the new cases, whereas prevalence is a static measure accounting for the total number of existing cases. Exam pearls right here. The incidence formula looks at new cases, while the prevalence formula looks at existing cases. Their interdependence is absolutely key. Prevalence is approximately equal to incidence multiplied by duration. A patient with advanced diabetes needs a right above knee amputation but refuses surgery. A relative wants it done. Without surgery, the patient cannot survive. What should be done? A, do firm counseling and get signed consent. B, tell consequences, defer surgery and document it. C, do relevant counseling, get signed consent and document all details. D, refer the patient. Or E, proceed without signed consent. Correct answer, C. Do relevant counseling, get signed consent, and enter all the explained details in the patient's clinical notes. Mentally competent adults retain absolute autonomy. A surgeon must counsel, defer if firmly refused, and meticulously document. Time for exam pearls. First, the autonomy rule. Family absolutely cannot override a competent patient, and there is no non-emergency surgery against their will. Second, the documentation defense. Customized risk disclosure notes provide your strongest legal evidence. With respect to patient safety, an incident that was prevented from doing harm to the patient is known as A, an adverse event, B, a near-miss event, C, a total miss event, D, a no-harm event, or E, none of the above. Correct answer, B, a near-miss event. This is an operational error or safety deviation that had the full potential to cause patient harm, but was intercepted and mitigated prior to ever reaching the patient. Exam pearls. An adverse event reaches the patient and results in documented harm. A no-harm event reaches the patient but does not result in injury, usually due to pure luck or immediate mitigation. A surgeon performs surgery on the wrong side of the patient. What is this termed with respect to patient safety incidents? A, adverse event. B, near-miss event. C, total miss event. D, no-harm event. Or E, sentinel event. Correct answer, E, sentinel event. This is an unexpected occurrence involving death, permanent harm, or severe temporary harm, entirely unrelated to the underlying illness, requiring an immediate root cause analysis. Here are your exam pearls. Classic sentinel examples include gossipoboma, ABO incompatibility, and wrong family discharge. The system's distinction is crucial. An adverse event is a standard error, while a sentinel event is a catastrophic systemic breakdown. Researchers study factors associated with pseudomyxoma peritoni, a rare cancer, in appendix cancer patients. Which study design or measure is most appropriate? A, t-test, B, ANOVA, C, chi-square, D, odds ratio, or E, relative risk factor? Correct answer, D, odds ratio. For investigating etiologic factors for rare outcomes, a retrospective case control design is the most practical choice. Its standard statistical measure is the odds ratio. Let's hit the exam pearls. Odds ratio use cases apply to categorical data in case control frameworks. Relative risk restrictions dictate that it requires a cohort study, which is highly inefficient for rare conditions. Unaware of how to fix a particular histopathology specimen, it is safe to store the sample temporarily in which of the following? A, empty bottle at 4 degrees Celsius. B, preserved in glutaraldehyde. C. Frozen at 0 degrees. D. Normal saline at 8 degrees. Or E. Pyridine solution at room temperature. Correct answer D. Normal saline at 8 degrees Celsius. This prevents drying and degrading. Temporary storage in normal saline at 4 to 8 degrees preserves tissue integrity until proper 10% neutral buffered formalin fixation can be performed. Check out these exam pearls. Saline limitations. It's not a fixative and actually damages tissue after minutes. Formalin function. It cross-links amino acids and completely prevents autolysis. What is the purpose of a frozen section? A. To determine grade of malignancy. B. To rapidly determine the nature of tissue. C. For lymphatic clearance. D. To look for vascular invasion. Or E. None of the above. Correct answer B. To rapidly determine the nature of tissue. It's an intraoperative diagnostic tool using fresh tissue quickly frozen in a cryostat to guide the next surgical steps within minutes. Final exam pearls. Primary indications for a frozen section are to differentiate benign from malignant tissue and to clear margins. But inherent disadvantages include ice crystal artifacts, unreliability for grading, and a much higher infection risk. As you move forward, just remember, in these intense high-pressure surgical scenarios, one single missed operational standard or one misapplied statistic has the power to radically change a patient's life forever. Think about the gravity of that. See you next time.